I'm Cadwallader-Allan. I'm an analyst with NHS England in the Midlands region, and I focus on diagnostic data. So just to give you some context about diagnostics, it obviously covers tests and procedures like your scans, your endoscopies, pathology, and physiological sciences. Demand for diagnostics has increased as the whole NHS demand has increased, and there is a target to get to 99% of patients should wait less than 6 weeks, but that's not been seen since February 2017. So during the COVID pandemic, NHS England commissioned Mike Richards to do a review and sort of recovery plan, and out of that, NHS England organised a multi-million-pound transformation programme to sort of implement these findings. The review did say that the service was severely lacking data. It's one of the areas in the NHS where the data isn't there. And so I joined as a data analyst in the team in September 2021. And it was my first proper full-time analytical role. I'd worked in finance previously, so I was a newbie as such. So I was a newbie, we had a brand new programme team, and they didn't know what data was out there, so I felt like that person. I was like, where am I, what am I doing? So I went through these 4 stages of a discover stage to see what is out there, a define stage to define what we wanted and what we needed, develop stage, and then delivered some tools for the programme team, and then those delivery then led on to decisions and outcomes. So the discover stage that I went through, I approached initially my analytical colleagues in the Midlands region. There was a couple that knew something about diagnostics, but there wasn't much out there. I approached national analysts who had a bit more comprehensive knowledge of what was collected. The regional diagnostic team, which was a new team in 2021, had a few operational and managerial people with experience in diagnostics, so they did have some insights, and we had some clinical people in there as well. Obviously did my own research, and I tracked down any existing reporting. If it mentioned the word diagnostics, it was sent to me, and I was able to try and trace back where that data came from. So I ended up with these sort of key data sets. The DMO1, which you'll probably hear it be called as, is the diagnostic waiting times and activity. So it's monthly published, but it's normally about 6 weeks out of date. So during COVID, they set up a SITREP called the Weekly Activity Return, which was a subset of the DMO1. Waiting list minimum data set was a patient level, but it was the very early stages for diagnostics, so data quality or data completeness wasn't really there. There was an annual collection for national imaging, which was NIDC, which covered a snapshot at the 31st of March. And there was some diagnostic imaging data set, but there was some transition during that data set. So some of it was restricted because it wasn't matching in all the different sources. So then I went on this define stage, and the pillars that made up diagnostics, the imaging, endoscopy, physiological sciences, pathology, and then we had these new community diagnostic centres, the CDCs. And I came up with these key metrics from the planning guidance and from the recovery plans. So there was a target to increase activity to a minimum of the 120% of the pre-pandemic levels. There was obviously to get the increase in patients back to receiving a test within 6 weeks. So we set a March 25 ambition for 95%. And then there was this big multi-million-pound rollout of community diagnostic centres. And so there need to be investment plans and evidence behind where we were going to put these and what we were going to put in them. Also, there was the other regional team setting up their diagnostic programmes. So I was the first regional diagnostic analyst. So I just contacted them as they came on board, and we set up our own little forum so we could share what we found and help each other out, basically. So there's 8 regions in NHS England. So that data and sort of the definitions and the metrics got to what I had and what I had to work with. So I went through a develop stage, and I did an almost like a quadrant analysis of what data was already collected and what data was needed in terms of reporting requirements. So I mapped them to sort of prioritise my work. Imaging data is well established. Mike Richards mentioned that in his report, that it's the best data set for diagnostics, but it was still a reporting requirement to monitor that. So, but that wasn't an easy win to turn that around. Physiological sciences, there was a very small number in DMO1, but it didn't capture the full 8 sciences that are in there. But there was work starting within the region to do with their own data collection with a clinical input and a HACA day. So that was good to join as they were developing that. Endoscopy features in DMO1, but it only features for the 3 diagnostic tests. So the broader endoscopy service, including your screening and your therapeutic, aren't captured anywhere. Pathology, there was very little data, but that was such a key one because that leads to the cancer with the histopathology work. So that was definitely one we needed to do a new collection and set up. And there was early stages of the CDC program, so our new activity data would come along as CDC's built on. And then we had this COVID weekly sit rep. Because of the delay in the published DMO1 data, we needed that to monitor recovery. So we set up for the pathology a working group with clinicians and histopathology people and designed a data collection. We had a task and finish group. And all through the different data sets and different new collections, we made sure we involved clinicians and involved people out in the trust land that would capture this data. And so it's not just another NHS England have told us to capture this and we can't do it. We wanted to make sure everybody was involved in discussions. So once we had all this data, and after many times developing Excel dashboards and sending out ad hoc reports, we went on to the deliver stage, which I basically made a Power BI app. So each diagnostic is contained in this one place. It's like a one-stop shop for people to access. But more importantly, what came of this. So this is some feedback from all my stakeholders, the program team and some of the ICB and trust people about what they've done with my data that they couldn't do before because it wasn't there. So you can see there's informed decisions on investment. They can target support and even development of data skills because there's people in the program team who don't do data, but I made it in such a user-friendly way that they now use data as part of their day job. But I just wanted to highlight a important sort of outcome. So that's Peter Bill, the Regional Chief Healthcare Scientist for West Midlands. And he was fundamental in getting this physiological sciences data return off the ground. And his quote there, I'm going to jump down to the second paragraph. One example was in-month increase in waiting times with corresponding decrease in activity of an audiology service. This data allowed a conversation with the service which highlighted an acute staffing crisis and supported early intervention recovery. Without the data, we would not have been able to act so quickly. So that is really something I'm sort of proud of because my data has had an outcome and you can really see it. So it's not going to stop there. The increase in data that we've got, the improvements in data quality, because I have a focus on that each month. I attend a diagnostic board and highlight data quality issues. And so we can focus more on to some more forecasting and modelling, some more sophisticated productivity analysis. I'm hoping to introduce some health inequalities work. And then I want to join up with other areas like cancer, which obviously does link in with diagnostics quite well. Overall, the aim to deliver the better services and outcomes for patients. And that's me.
That's great, Lee. Thank you very much. And for keeping to time as well. Sorry, it's very distracting. People waving yellow flags at you, but no, thanks for that. So is there any... Feel free to...
So yeah, we've got 2 quick questions. Why did you decide to collect data for your region only rather than lobbying for a national collection?
There had been talk of a national collection, but the pace of that was quite slow, and we had real engagement within the region. So that's why it went down the route of, obviously, Pete Bill, the chief scientist, doing a regional collection, which now, incidentally, the national team are now looking at potentially to implement nationally. So it's we did approach national, but it was just the pace, really.
Excellent. Yeah, I was going to ask you whether that might have helped support the case for national, but you've completely tied it in. So the other one is, are you able to capture a report on inequalities in access to and use of diagnostic services?
The trouble we've got with the diagnostic data is it's the only patient level we've got is the waiting list minimum data set, the weekly snapshot. So we are going to start working with that, to doing inequalities work. But I think that's always been the challenge for diagnostic, is getting some data, let alone the detail that we needed for further analysis.
I think we've got time for one more question, and there's another question that maybe you can pick up afterwards if we pass it through to you. But how do we access your work?
It's accessible with an NHS Net email address, because I can add you as permissions onto the Power BI. And yeah, I didn't put my email address on there, but yeah, just contact me, l.cadwallader-Allan at nhs.net. But there's also the Midlands Diagnostic at nhs.net is a team as well, so they will be able to help.
Are there any questions from the room before we close the session? No, okay, looks like
There's one more from Slido, actually. So we have real problems with diagnostics data and respiratory care. Are there any key gaps in diagnostic data that you see and think needs improvement?
The physiological sciences, which obviously respiratory falls under, is still a work in progress. But what we've done is included the clinicians, like I said, that they came up with the granular lists of how to group tests and what sciences they go into. So yeah, it's a work in progress, but we're getting there. It's just it's one of those things that's never been collected before. So you've got uniqueness of each provider and each system.
That's great. Thank you. Just from a selfish point of view, also, Lee, I'd like to extend an invite to our Midlands Analyst Network as well. So I think that some of that stuff on what diagnostic data is available and what can be done with it is really useful to a wider audience again. So thank you very much,
Cool. Thank
Lee.
you.